Yeah, we can hear. Can we hear it now?
Yes, we can hear you.
Yes,
There
I
you
can
go.
hear you.
Thank you. Good. Thank you. You too.
Jonathan, depending for virtually.
Ruth here.
And, it's time a little bit later. No rest for the wicked. Thanks. Enjoying summer, not long. I can't see you guys.
All I see is you and someone else. Oh, I can't see the lobby. Maybe because I'm not in my own, like.
Between 11 and 3.
Everyone, sorry for the delay. We had a little bit of a issue getting the room set up here. We're just gonna take a minute to look for a forum and I'll release the room now when we establish that. Everyone about 7.
Hi, Callie.
Hi.
Dear Mary.
Kathy.
Hi.
Morning, everyone. We do have a forum. Excellent. Hey, good morning, everyone. Welcome to summer. Welcome to the pawning, as I like to call it. It's nice to get together. It's weird on this every few month cadence, but we're figuring it out. So I don't think we have any introductions or any announcements. Beyond that, Henry's gonna have to leave us early for an meeting. And Olivia will leave us about 15 minutes early because she's got a high priority. And we will weather through. So I think that covers our announcements for tonight. Sorry, lights are flashing. All right, so we do have a number of items on the consent agenda. And if memory serves, all of these rules are being readopted with minor or no amendment, with the one exception of doula services, the first rule on the list. This is a new rule, and this was a service that was authorized by the omnibus legislation of a couple of years ago. That's correct. Yeah, this is our administrative rule to establish doula services as a covered Medicaid service. So at this time, I would ask, is there anyone who has a reason to recommend that one of these rules be taken off of consent and instead become a discussion item? I'm not hearing anything, so I assume that means that we are okay to move forward with the consent agenda items, and I can't ever remember to vote on the consent agenda. No, I think if there's one motion to take something off consent. Yeah. Great. All right. Our next agenda item is a review of the March 9 minutes. You're crazy if you feel like you didn't get them because they are behind. So we will not be able to do review and approval of the March minutes today. Moving right along, we are still holding on to a discussion item for direct support workers and workforce issues that they are facing, but the department is not ready to move forward with that item just yet. And I would just use that as an opportunity to say that over the last few months, as and working with Olivia and Kristen and Henry, David on reviewing agenda items, it's a lot harder to do a year's worth of work in 6 months. So we've been really trying to be mindful of, how do we streamline some of the information? How can we engage the membership a little bit more between meetings? And I would say, we're still sort of figuring some of that out. So if you see something that's hanging out there for a minute, please keep in mind, we're trying to figure out how to disseminate all of this information with far fewer opportunities, half as many opportunities to have those conversations. So with that, Olivia, do you want to talk about sort of the MAC, BC administration, how are things going?
Yeah.
What do we need to know?
Thank you so much. So I'm gonna cover updates on the Beneficiary Advisory Council, and then we have a topic on our Medicaid Advisory Council administration as well. On the Beneficiary Advisory Council, we had a meeting on May 20th. We had 5 of the members present. We had 2 new additions to the group, which was very excited to welcome them and their perspectives into the group as well. We had a few different key topics in that meeting. One was around governance and bylaws of the BAC, since this is a newer group and aspect of our Medicaid program. A couple things to highlight there. I know there had been some questions about if you're not a part of the BAC, can you attend the BAC? And one thing we discussed in that meeting was really just handling this on a case-by-case basis, since there could be sometimes that we have a meeting where folks may share more information that they wish to keep in a closer audience. This isn't meant to be overly restrictive, but what we'll do is if anyone's interested in joining a BAC meeting, please reach out to me and Kristen, and then we can, check in with the members if there's any preferences for the upcoming meeting about opening up to external attendees. So unlike the MAC, which is always a public meeting, the BAC is going to be a bit more flexible to allow smaller, more private participation where appropriate and preferred by the members. The other update on just sort of managing that group is we're almost through reviewing the bylaws. And so once those are finalized, we'll distribute that to both groups for awareness. Folks will recall we sort of had a draft bylaw to start things off, but we've been making some updates based on the Beneficiary Advisory Council members to kind of make that more in line with how those meetings are going to run. Other topics that came up in that meeting, participants shared really helpful information and perspective on challenges that they've had with accessing NEMT transportation. So informing some follow-up on the department side, as well as observations around service authorization, MCO. This has not gone smoothly in the past. In terms of topics that are being recommended for the MAC, the group recommended that the MAC continue to keep on its agenda the changes on the federal and state level coming to the Medicaid program. So these are Medicaid work requirements, 6-month redeterminations, other major changes, with a special focus and discussion on noticing in this area, the letters and notices that beneficiaries receive, and really helpful info was shared around those notices not always coming in plain language historically, and sometimes taking a tone of kind of reaching more punishing or discouraging, and so I was just the importance of us looking at the tone we're striking in those notices as we develop them. None of those notices exist today, so I think upcoming, as the department drafts them, we'll be sharing it with the BAC to take a look at how the department is talking about these programs. Another topic that was raised by the BAC back in the fall, there were some really concerning incidents regarding safety for some of the waiver recipients and really concerning events that were happening in their care. This is obviously a huge priority for the department. At this time, DHHS is collaborating with the Attorney General's office on doing a systematic review of those events that arose in the fall. We will be sharing more information on that once that effort's further along, but I wanted to state it as a topic of interest and priority to the BAC. So coming up on the BAC front, we'll be finalizing bylaws, as I mentioned, reviewing beneficiary-facing materials as the department takes on some policy changes. And then my final note is that we'll be preparing a annual summary of MAC and BAC activities. This is part of the CMS requirements for MAC and BAC. And in our upcoming MAC and BAC meetings, we will share that draft so that folks have a chance to react and contribute to it. Any questions on the Beneficiary Advisory Council? Karen?
Thanks. I wanted to make sure I understood correctly. So as far as MAC members attending BAC meetings, do you need to be notified, like asked about this every time or one time if someone is interested in joining?
I think for now, every time would be helpful as we just kind of work out that process. You know, it's a fairly new group and we have new members as of the last meeting. So I would say if you're interested in coming to the next meeting, just reach out to me and Kristen and we will touch base with the members.
And you'll be able to do that before, like, I'm just trying to figure out logistically how that would work. So if someone like tomorrow would like to attend the next BAC meeting, would they be able to know before the next meeting that they are in fact either allowed to or not allowed to attend?
Yes, I think as long as we hear from folks. I mean, there's a couple people that I know asked about this in the last meeting. So if you've already asked us, we are going to do this for the next meeting. We just wanted to talk to the members first.
Okay.
But yes, it'd be great to just get an email saying you're interested in attending.
Okay, and then one more question. Are the BAC meetings minutes going to be posted on the website?
We will be posting summaries of what's covered in the agenda and discussing the meetings.
Okay, thank you.
Thanks for your question. Any other questions about the Beneficiary Advisory Council? Great, thank you. Next, I wanted to speak to officer nominations. So, sorry, Dr. Watts, I see your hands up.
When is the next BAC meeting? Just curious.
So we schedule them around the availability of members. Since it's a smaller group, it's feasible to do that. So if you want to reach out, we will let you know when the next one is, and we can, like I described, just see about others attending the next meeting. Any other questions? Okay.
Hi,
So
Ellen?
Hi, sorry, there apparently is no mechanism that I know of yet to be able to raise my hand. I've been trying to figure that out, but I just had a question. When concerns are brought to me that are issues that beneficiaries are having, it seems like it might be more appropriate for me to contact you about that and see if there's any other experiences with the BAC that are similar rather than bring them to the attention of the meeting of the MAC as a whole. Would that be accurate?
Olivia or I, if we want to deal with it as soon as possible. If there's something systemic about it, that may be something that we will bring up at the PAC.
Okay. All right, thanks.
We want to take care of these as fast as possible.
Right. Right. Well, I mean, an example would be I'm getting a lot of complaints from people about how difficult the process is now to get mileage reimbursement from medical trips, and that it's much more convoluted than the previous process, and people just are giving up because it's so difficult. So I just didn't know if that was the sort of thing that would be, I mean, I'd like to know if other beneficiaries are having that too. So that's just an example. So.
Yeah, that's a systemic type of situation, I would think. Part of it also too is that it's been an area of multiple fraud situations, and so that in New Hampshire within the program that have been prosecuted by the Attorney General. So there are aspects of making sure that that isn't happening, and so
yeah.
You do need some. It's good to have some specific cases to look at to see what's going on, whether it's an administrative issue you can smooth out versus, it may have been too loose before in terms of the requirements. So
Right.
we need some specific cases to look at. See
Okay.
those would be
All
good
right.
too.
Yeah, be glad to do. And then one sort of thing is that it seems that there's a much shorter turnaround now. They have to submit them by the end of the month instead of having a 3-month grace period and that sort of thing. But I'll be in touch with you about that. So thank you. Thanks.
That one would be a good example of something we may get smooth on administratively, because I'm not sure the rule against that.
Raising that. Marissa?
Hi, so I had a question. I know you mentioned that the BAC would be scheduled around their availability. But I know that at least the interpretation at the time was that the BAC had to occur before an MAC meeting. And so how frequently are you planning on having the BAC meetings, just because it impacts the frequency of ours?
That was probably confusing. It does meet before the month prior, every MAC meeting. But for the MAC, we have this kind of prefixed time. And at least at this point, we don't have that with the BAC. We're reaching out to folks to kind of see when in the month works for them. Does that make sense? So it does follow.
Yeah, it does. I guess I am looking at the fact that the MAC hasn't met since, in several months. And there's a lot of, and I had shared this, I think, at a previous meeting, that there's a lot of really valuable information that's shared at the MAC, and I'm finding that there's a gap. I would love to get some of that information to share with our members. And I don't know if we're going to be able to do that. I know there's balancing like the availability of the BAC, but how do we access the information that is brought forward in MAC as well?
Can you ask that another way? I just want to make sure I understand. So we are on the quarterly calendar now for MAC.
Okay.
So are you just saying that? Just sort of
So
that.
So the quarterly is for MAC is going to be like, from now on, it's going to be held every quarter. Is that accurate?
Yes.
Okay.
Yep.
All right. I guess I wasn't understanding that. Thank you.
Sorry about that. I can share with you. I think we put together some visuals for this, but when we were kind of making updates to the forum, so I can share that as well to this meeting.
Maybe we can publish the dates going.
Yeah.
Kristen, put that together.
For instance, I think, you're really framing what we've been talking about, which is how to make sure that the MAC membership are receiving the information that they are accustomed to in spite of a very different meeting schedule. And some of that, I think, is going to be that materials and communications come out outside of meetings or outside of sort of the prep for a meeting. And, you know, it's there for the members to consume or not as they see fit. As we get a little deeper in the agenda, we can talk about, you know, some of those customary, you know, bits of data and information and why they haven't been forthcoming, but it's more of an agenda item. So if we could beg your patience just for a few minutes, that would be great.
Thank you.
Are there any other questions about the BAC? Because I do want to make sure selfishly that we talk about officers for MAC. Of course, Kelly's in my term, we are term limited, so we cannot serve again at this juncture. And I know Krista has been great about flagging that in our prep material. So I'm hoping that folks have some ideas, or maybe there's been some conversation about who might be in a great position to be the next chair and vice chair of the MAC.
So I'll just say to, you know, Kristen, I've solicited out sort of who has nominations to share. We haven't received nominations offline via email. So we wanted to open the floor. In this meeting, if there were any nominations, but I think if there are not, then maybe we can talk to about maybe convening like a membership committee or something like that to sort of help source potential interest. Go ahead, Carolyn.
Hi, good morning. Thank you. In the past, and I know things are a lot different now, if someone served as the vice chair, that did not preclude them from serving as the chair. It happened frequently. And the communication to date has been that Kelly is not eligible to serve as the chair, and I believe she may be. So if that is true, I would nominate Kelly Cappuccino as the chair.
Thank you for pointing that out. I will double check that. I think you may be right that that the vice chair could be eligible to be the chair.
Is the inverse also true?
Like you being vice chair?
I'm not volunteering. It's more a point of curiosity. And
I believe that is the reverse is true as well. I think the term limit is on the singular position. Does that make sense? I served as the vice chair for, I think, 2 terms, and then served as the chair for 2. And that happened pretty frequently over the years. I could go back with specific examples, but if it's not true today, it's not true today. But I would like to understand why that's no longer true, if it is no longer true.
I don't think.
We have the bylaws with us.
Yeah.
So I think the term limit was on the absolute time someone could serve. Right? That was like, we went with 7 years or 5 years.
That's for the membership term limit, but that's different from the officer term limit. But I believe Carolyn is correct that while there's limits on, you know, how long a chair can be a chair and how long a vice chair can be a vice chair.
It doesn't say.
Vice chair doesn't preclude you from being chair, and chair doesn't preclude you from being vice chair. So I'll do a double check, but I don't think, I know we certainly didn't like intentionally take that up in the bylaw group last year, but we'll double check to just make sure there's nothing in the bylaws that says otherwise. But I believe you're correct, Carolyn.
I just want to highlight that, you know, Kelly isn't here today, and I don't have any firsthand knowledge of, you know, whether she would be open to becoming chair. And I just don't want to jam her up. I'm happy to have the conversation with her outside of the meeting, obviously, or Olivia, if that's more appropriate for you to do it. But I just want to make sure everybody's aware that she's not with us today, and I don't want to assume I know her intentions.
I was not assuming I knew her intention. And the other thing that's important to realize here is just because someone is nominated, they don't have to accept the nomination. So I didn't mean to infer that I knew her intent. I don't. But she can always refuse the nomination.
Oh, Jonathan posted in the chat.
I just posted the limit there that's as it's stated in the current bylaws, so. I can see why it would be interpreted as neither person would be eligible to serve another term as an officer in any office
Yeah, I saw
based on
that
this
section.
language.
Yeah. But then we also have the section above it that says the vice chair will not participate in the nomination process if his or her name is to be put forward in the nomination for an officer position, which I think is meant to address, if the vice chair is being nominated for chair. I'll just say I know that, like in the discussions we had about the bylaws, there was not kind of an explicit proposal from anyone to change this. So I just want to be forthcoming about that. But yeah, I understand the language is a little vague. So I think probably if you agree with this, it makes sense to have a membership committee meeting. Okay. To take up the Carolyn's nomination and any other nominations we might receive. And I was wondering if folks might be able to volunteer themselves to participate in that membership committee, subcommittee.
I would participate.
Thank you. Any other members?
I do.
Okay. I'll just put out the ask that I think if anyone is willing to consider participating in the subcommittee, I think it would be really helpful to the department just as we kind of continue to make this transition into the group. So, feel free to reach out to me and Kristen if after more consideration, you think you could give some of your time to that. I think it would just be helpful to make sure we can move forward with full seats on our officer leadership. Okay. Any other questions on MAC, CIT administration topics?
Okay. Moving right along, we have, so here's an example of really bringing some brevity where we can. So in years past, when we've had the EQRO report, it's been a very lengthy presentation. Based on the level of engagement and interest, we're going to do something that's much more substantive of the EQRO most recent evaluation of the MCF. And we have Erin?
Yes.
Yeah.
Excellent.
Hi, good morning. Can folks see me and hear me okay?
Yeah.
Yep.
Okay, great. So yes, thank you for the time today. I'm Erin Metcalf. I'm the administrator for the Medicaid Quality Program. I'm here with Jill Fournier, who oversees the EQRO contract for the managed care program. Briefly, by way of background, since it doesn't come up often, EQRO stands for External Quality Review Organization. Since New Hampshire is a managed care state, we're required to have an EQRO, and they provide an assessment of MCOs, and in our case, a dental organization, their performance as it relates to quality, access, timeliness, experience of healthcare for members enrolled in managed care. This is achieved through a series of activities. Some are required by federal regulation and others are optional. And as mentioned, we've had lengthy prior presentations by our contractor, which were very detailed and informative, but they're also, took up a lot of real estate on our tight agendas. So we went with a slightly different approach this year. So what we've prepared and what we've sent out is more of an executive level summary of our major findings for the required activities. I will walk you through them for both the MCO and the DO. They're 2 pages, so it won't take long. And then at the end, I'll point you to some additional resources. There may be a few minutes for questions, but I also want to extend the offer from Jill and I that we're always available to come back to a future meeting and present in greater detail on whatever might be of interest. So with that, let me share my screen. Right. Can folks see what I'm sharing in the room and online? Okay, great. Great. So this top part was just kind of what I mentioned, and I'll just get right into the meat of it. We're going to do the MCO one first. This is the MCO technical report summary. You scroll down. Sorry, this is a little bit different. It's not a PowerPoint format, so there'll be just a tinge of scrolling. Apologies for that. So for contract compliance, there are 18 total standards. In New Hampshire, we review about a third of them every year. So in fiscal 25 for the MCO, the EQRO examined standards 2, 4, 8, 9, 10, 15, and 18. Each standard is broken down, the way these work, into kind of a series of elements. They our EQRO, HSAG, they meet over a 2-day contract compliance kind of virtual review, and they do a deep dive into each of these standards. And the standards, as I mentioned, are broken down into a series of elements. Some of them have hundreds and hundreds of elements, so there's lots and lots of work going into these contract compliance review audits. And the HSAG, our EQRO, is looking for policies and procedures and checklists, and there's file reviews. And if the MCO meets the requirements for the element, it's marked as met. If they partially meet it, it's marked as partially met. And if they don't meet it at all, it's marked as not met. And then there's a formula to determine kind of overall contract compliance rate, which is what you see here. So ACNH had a contract compliance rate of 99%. New Hampshire Healthy Families came in at 98.7%, and WellSense came in at 97.8%. Any standard that is below 100% results in a corrective action plan, and the MCOs are required to respond to those. And so usually within very short order, and it's true for this year as well, the MCOs are 100% compliant with all of these standards. Scroll. Performance measure validation is another required EQRO activity. In New Hampshire, we tend to focus our resources on validating state-developed metrics. As opposed to HEDIS metrics, the MCOs have their own HEDIS vendors, so those are kind of independently validated in that process. So we tend to select state-developed metrics, usually around 20 each year. And the EQRO does a deep dive with each MCO to determine the confidence that they are accurately capturing the metric according to the state's definitions. This results in a confidence level, and you can see all 3 MCOs had a high level of confidence for their performance measure validation activity. There were no significant issues uncovered. No metrics were required to be resubmitted. There were a few recommendations, one for each MCO. So AmeriHealth and New Hampshire Healthy Families were recommended to explore opportunities to automate metric calculations, and WellSense was recommended to incorporate more stringent validation checks. But overall, still a very high level of confidence with our performance metrics last year. All right, so for network adequacy validation, this is another required activity. It's a fairly extensive activity. The part that most people tend to want to know about is the time and distance standards, also known as the geo-access analysis. So in New Hampshire, in state fiscal year 25, the EQRO examined 61 provider categories for time and distance requirements. And you can see the results here. So AmeriHealth achieved 95.1 of those time and distance standards. New Hampshire Healthy Family, 98.4, and WellSense, 96.7. All of the missed standards were for these kind of pediatric specialty categories, and I've listed them here. And it is important also to note that the MCOs in every case had documented exception requests and corrective action for all unmet time and distance standards. And for encounter data validation, this is, of course, a very important and required activity for correct claims and payments. And there are 3 tasks that our EQRO completes. One is an information systems review. Another is an annual evaluation of encounter data quality reports. And the third is this large comparative analysis, which the results of that is what's in this table here. So across 154 encounter data rates, ACNH had no significant findings, which is great. New Hampshire Healthy Families had 2, one related to submission of claims payment detail, and another around the rendering provider NPI accuracy. And for WellSense, there were 3: the validity of the member identification number, again, the similar one to New Hampshire Healthy Families, the claims payment within 14 days, the timeliness of that, and then the accuracy for rendering provider NPI number. I will talk through this bottom kind of purple box when I get to the bottom of the DO, because it's almost exactly the same. Are there any brief questions on MCO EQRO activities?
Erin, how do the overall findings compare to years past? Are they roughly the same? Do we see different plans sort of falling in different order than how they present this year?
I believe they're largely tracking in years past. I'd have to do a little bit more of a robust analysis to kind of compare, like the last time we had these contract standards, how they did. But I don't believe there was any major dips, or I think it's largely tracking improvement where we're hoping to see improvement, and steadiness where we hope to see steadiness. Any other questions on MCO? All right, so moving on to dental. We've the same required activities we selected to present here. And obviously we only have one dental organization, so the charts are a little bit abbreviated. There were 6 standards on the dental side of things that were applicable: 4, 8, 9, 10, 15, and 18. We did, the version that I believe we sent out did not have this note. Jill and I were chatting before the meeting, and we wanted to make sure that we explained this one a little bit more, and Jill is going to pipe in here for a second. But the overall contract compliance results were 69.5%. And all of these standards, the 6 that are listed here, were between 83.9% and 100%, except for standard 9, which is this grievance and appeal system, which came in at 62.6%. So this was the one that was kind of dragging down the overall contract compliance results. And Jill, I don't know if you want to speak to briefly the details behind this standard.
Sure. So the reason that the overall rate was only 69.5% is that there were 226 items included under the grievance and appeal systems, because it included various checklists, such as an appeals checklist, a state fair hearing checklist, notices and continuation of benefits checklist. But what really pulled it down was the grievance and appeal file reviews, which were done. So for the grievance file review, 26 of 51 items were not met. And for the appeal file review, 42 of 108 items were not met. And those were things such as time to notify the member that they had received the appeal or grievance request, or there were missing data items in the letter itself. So it's very crisp what needs to be in the letter. So for state fiscal year 26, we had HSAG do another file review, and we're waiting on those results, but I believe the results will be much higher for the state fiscal year 26. And this involved an internal meeting between the DO and DHHS, where we actually looked at some of the letters. They implemented a very extensive review process after these findings, where they have internal, extra internal reviews versus an automated system, which was accounting for some of the errors in it. So we are confident that we will see good results for state fiscal year 26.
Great, thank you. And again, there was a cap involved with anything that was below 100%, and the dental organization is now 100% compliant with all of these standards. So when we prepare this next year, this would probably be one that we would kind of highlight the improvement that we expect to see. For performance measure validation, the dental organization has a series of performance measures. We selected 18 of them last year. There were no significant issues discovered, no resubmissions required, and the result was a high level of confidence in their performance metric calculations. There was one recommendation to explore drivers of the decrease noted in the auto adjudication claims processing rate. So they've done that follow-up. Network adequacy, it's a little different on the dental side. There are 5 provider service types that are evaluated for the time and distance standard, and the dental organization achieved 100% on their network for that. And for encounter data validation, the same 3 tasks were completed in state fiscal 25. And in the comparative analysis, there were a few findings. The validity for the member identification number for institutional claims came in slightly below the standard at 99.9%. Institutional claims in this instance are related to dental encounters in a hospital setting. And then there was some findings related to provider, NPI, and primary diagnosis codes. Any questions on dental? I see someone has a hand up. Karen?
Yeah, thank you.
Yep.
I mean, maybe I should understand this, but could you scroll up, please, to the first category? So I guess maybe I'm not really understanding, like, so in 30 days, they're now compliant. Like, how do you get to 100% compliance when you're at 69.5%, especially when you're looking at also like availability of services and access to care?
They had to
Okay.
respond to the cap that we prepared within 30 days with their plan to be compliant, and they are
Oh.
now compliant. Yep, we
So
followed
they're-
this for a few months. Yep.
So they're compliant. So now, like their numbers, like their grievance, so they've actually improved the appeals and grievance up to
Yes.
100% now.
They-
After
yep,
only
they
30
should be,
days.
and we're expecting the results of the state fiscal 26 contract compliance review shortly, and we'll be able to know for sure. Yep.
Okay. All right. Thank you.
Thank you for asking that. I had the same question.
Okay. Any other questions on dental?
So Erin, if I could just add that, they do their first submission of the caps within 30 days. If it doesn't meet our standards, then they have to submit an additional cap for the remaining items. And the items stay open until they can show the documentation of, say, an updated policy that includes something that may have been missing in the policy that should have been in there. Or in the case of the file reviews, it took us a few months really to agree to the corrective action plan. So it involves separate meetings. So the initial response is within 30 days, but sometimes it takes months for certain items to bring them into compliance.
Any
Hi,
other
this
questions?
is Joan Yes, this is Joan Fitzgerald from the New Hampshire Dental Hygienists Association. I'm just interested, could you clarify who the 5 provider service types are?
Oh, let me see. I know one is, Jill, do you have that ready at all?
I can look that up, but I don't know off the top of my head.
While she's looking,
just get
if there's another question, we can move on to that, or I can do this little bit at the end here. Not hearing other questions. So just briefly, and we'll come back to Jill in one moment. If you have not visited our Medicaid quality site, please do go there. It looks like this. You can find under standard reports. Of course, it's taking a moment, and then scroll down just a little bit. We have a whole section here about EQRO technical report. We have featured here the state fiscal 25 full reports that are, very lengthy, a couple hundred pages, but we also have some summary PowerPoint slides, which might be helpful. And then I can't remember who asked, but if you're curious about prior years, you can go to the archived section, and we've got 24 down to 2014 all archived out there. And so, please do go out there if you have a few minutes and want to check it out. And then I have links embedded that will take you directly to the full report or the location of those detailed slides. And feel free to email us. My staff monitors this this inbox. So happy to answer any other questions. Jill, do you have those provider types?
Oh, there we go.
I'm getting there. I'm on the MCO. I'm sorry. It'll take me just a minute.
Any other questions that I can help answer?
Can you hear us in the room? We lost our connectivity in the room for just a couple
Oh,
seconds.
yep, I can hear you. Sure. Do I need to go back to anything?
I think we just missed your summary of the website, but I think your connectivity was fine. It was the physical room connectivity.
Sure. Yeah, just feel free to click through these links. They'll take you to the more detailed information out there. Cheryl?
Yes, I was wondering, are there any participant complaints added into this quality report at all?
So we do have, and yes, we have. So in addition to the standard items that are the required items that we went through, we do have reports about performance improvement projects, quality studies, and importantly, we have member focus group studies that are also out on our Medicaid quality website, and there's some really rich detail in there. We our HSAG subcontracts with Horn Research to do member-focused interviews on, a variety of topics, and we do 2 a year, and those reports are out there. And here's
Okay,
Jill.
thanks.
Yep.
Alrighty, can you see my screen?
It's coming, Jill.
While we wait on that, Erin, how can the members find the material you were just presenting on? I don't see it hyperlinked in the agenda.
So the 2-pager is a summary of the technical report. And at the bottom, there was a direct link to the full technical report for both the MCO and the DO. And there's also a summary slide deck. Both of those are posted out on MQIS.
Okay.
And we emailed.
Did you get?
Oh, you did, okay.
Yeah, it was with the agenda.
So this is Jill. Can you see that,
Yep.
Erin?
Yep.
Okay, so these are the 5 categories. With
So
the
dental
rates.
restorative services. Yep, so they're listed right there. And this is a little
Thank you
bit
for that.
different in the dental contract. We don't have it listed out by county. We kind of group the counties into urban, middle, and rural. So that's how it differs a bit from the MCO side.
Thank you very much.
All right. Please reach out with any questions. We're happy to come back at a future meeting. Thank you.
Thank you.
So you'll let us know if you would like, have the chance to spend more time with it, whether they'd like to come back next month or next quarter.
Sure thing. Or whoever succeeds me. Did I see any stuff in the chat? Chris, it looks like you're on.
Yeah, I'm just catching
Yeah, so
up.
we,
Sorry.
Carrie raised a question about becoming a member of the NEC, so we can send you the application for that process is followed for this meeting. And then Dr. Lawson, sorry, it sounds like you didn't see Jill's speech there, but we can maybe Jill, if you just put in the chat what the 5 types are.
Just take a screenshot.
Or a screenshot that can help.
Yeah, I'll find that and do that right now.
Thank you.
Moving right along, Rob is here with what I assume are some summer interns.
They are, yes. So I have 3 summer interns with me. I have Wentow on my far left. I have Lucas in the middle, and I have Emma Amick on my immediate left. Will be joining us for the summer.
College, I think?
UNH. Wentow's a rising 3L. And Lucas. Oh, I'm sorry. I'm just so used to everybody knowing the legal law school terminology. 3L is the last year of law school, the 3rd year of law school. So she's in her last year. And Lucas and Emma are entering their 2nd year of law school. So they'll be their 2Ls.
Oh.
All right. So, Kristen, did you get the document out to everybody?
Sent it this morning. Hopefully people got it.
So we are at the end of the session. All bills have been acted on by the legislature. So now it's time for the enrollment process. It should be lengthy, as we all know, and governor action should bills have passed both chambers. So I'm just going to highlight a few of the bills that I think are
Yeah.
that are worth discussing. So I'm going to start with HB 392, which is directing the dissolution of the Department of Health and Human Services Office of Health Access and the Department of Environmental Services functions for environmental justice. And although it passed the House, it was ITL, which is inexpedient to legislate, in the Senate. Moving on down to SB 134, relative to work requirements under the state Medicaid program. I'm sure by now most of you know that that was signed by the governor on March 27th, 2026. Down to SB 454. Requiring the Department of Health and Human Services to update existing relevant public health outreach programs by incorporating information to aid public understanding and awareness of Alzheimer's disease and other dementias. That was passed by both chambers, and it has been enrolled and is awaiting action by the governor. It's enrolled in 5/14/26. SB 401 was a department requested piece of legislation, and that is relative to removing obsolete annual reporting requirements for, I'm sorry, let me try that again. Relative to removing an obsolete annual reporting requirement by municipal overseers of public welfare to the Department of Health and Human Services. And that was signed by the governor on May 8th, 2026. Moving on down to SB 454 was signed by the governor on Friday. Thank you. SB 455 relative to coverage for GLP-1 medications under the Medicaid state plan. Now, this is for the weight loss component only of GLP-1 medications. That was ITL in the House. Down to HB 1030, relative to licensed practical nurse scope of practice. That was passed by both chambers and was signed by the governor on 5/8/26. HB 1671. This was relative to prohibiting state Medicaid payments to facilities that discriminate against employees, students, or trainees for exercising lawful medical or religious vaccine exemptions. And that was referred to interim study, and it's in the chamber originated from the House. And then there's HB 1798 relative to the coverage of diapers through the state Medicaid plan. That was laid on the table in the House. And there's HB 1032. I thought this was interesting from an MAC perspective, creating an exception to physical attendance and form requirements under the right to know law for individuals with disabilities and individuals caring for a household member with disabilities. Now, the docket on the website reflected a miscellaneous status, and the last I saw was that there was a committee recommendation of ITL 10-8, and there was no action that seems to have been taken, at least reflected on the docket at the last House session. So I'm assuming it's just going to just die by that process, but I'm not exactly sure what that fully means. So I'm going to ask John Williams about that. But I saw a couple bills like that. So that was a procedural variance that I'm not overly familiar with in the legislative context. Moving down to HB 1763. Establishing a committee to study citing and maintenance rules regarding certain intellectual and developmental and required brain disorder. That was passed by both chambers. It doesn't look like the signing has occurred yet. That's study committee, and there's a report due, I think, on November 1st of 26 for that. Moving down to HB 1211, this is relative to the scope of review of state agency interpretations. This was one I was involved in. There was an effort to codify the recent U.S. Supreme Court overturning of Chevron in New Hampshire state jurisprudence, and more or less we already have judicial interpretation that follows that. But I worked with the AG's office to clarify some of the more ambiguous language in that bill. But the committee ultimately ended up, or at least the Senate, ended up referring to interim study, although it passed the House, because they did not like some of the language in it. So it ultimately did not pass. HB 1797, relative to eligibility for public assistance, including the New Hampshire Employment Program, Family Assistance Program, and SNAP. And that was referred to interim study in the Senate. HB 1337, repealing the New Hampshire Council on Autism Spectrum Disorders, and that was passed. So that will be enrolled and go to the governor's office for final action. HB 1727, relative to the interagency data sharing for the purpose of distributing summer electronic benefit transfer, EBT benefits. That's the House non-concurred with the Senate amendment, but ultimately, I believe it was adopted at the committee conference stage. Yes, it was. So that will be going to the governor for final action. Moving on down to HB 1584, directing the Department of Health and Human Services to provide notice of medical and religious exemptions from immunization requirements and relative to the form of such exemption. That committee conference report was adopted, so that will be going to the governor's office for final action from there. SB 663, creating a Medicaid methodology and working group within the Department of Health and Human Services. And that will be going to the governor's office for final action.
What is that substantively? What does that mean?
They want to consider whether to change any of the ways that we set rates for nursing facilities.
Oh, okay.
Yeah. It's a worthwhile exercise, but as long as there is a fixed pool of money.
Right. Yeah.
Moving money from one group to another group. So.
Yeah. Well, and as we've seen in the past, we have a methodology that requires payment that exceeds the available funds, and so we just suspend the methodology.
Well, actually, we do a budget adjustment factor, which is basically the work to make sure we don't exceed the amount that's appropriate. There's the HB 155.
Which is my next one I was going to. And in similar vein, HB 155, which is relative to business enterprise tax returns and appropriating funds in the Department of Health and Human Services for licensed nursing facilities. And this part of the bill that we were concerned about was an appropriation of $2.5 million. So 2.2.
It's 2.25. That will be distributed through the 504 kind of distribution based on patient days, and then additional monies of that's also a federal match. So
yes.
Double that 4.5 plus another 5. And then 75 such part for that.
Yep. And that bill almost was killed due to the business enterprise tax issues that have nothing with the nursing facility part, but they eventually came to an agreement on that. So that is awaiting government or governor action.
Am I wrong in thinking that sub 5 million does not make a huge impact?
It's really, we worked really hard to get that. So
I don't mean to minimize the effort. I just feel like I wish it was 3 times that.
Yeah, it's. between the two of them, it's almost $10 million, so. And half million to be exact, additional funding, so it is about 3%, it's already additional funding.
And then HB 1219, relative to immunization requirements in foster family homes and relative to financial eligibility for the Medicare Savings Program. That is also awaiting governor action. HB 1565, relative to the penalty for false reports of suspected abuse and neglect made to the Division of Children, Youth, and Families relative to UNRWA's project management services for school building aid projects and relative to long-term care eligibility and making appropriation therefore. That is also awaiting governor action. The part we were, at least Medicaid was most concerned about, was the long-term care eligibility. That was the provisional eligibility bill where they appropriated $1 for us to utilize. So we'll work that out. That is awaiting governor action as well. And then HB 1772, relative prescribing, think I'm gonna get this wrong, I'm gonna try. I advocate for investigational use only, adopting the physician associate licensure compact. The second part of that bill was part of the World Health Transformation Grant. So that's a part of that process. That is also awaiting governor action. And then last is HB 1735, that's relative to the practice of pharmacy, dispensing of certain medications by pharmacists and permitting treatment of certain severe illnesses under the Right to Try Act. And that was also passed and is awaiting governor action. So happy to take any questions.
Questions for Rob?
Cheryl?
Yeah, I was just curious whether or not you could send that report out to everyone.
Yeah.
We'll double check, Cheryl, make sure we have a copy in your email.
Thank you.
Thank you. Any questions? If not, I'm going to move to some updates on federal and state Medicaid policy changes for the rest of this agenda item. It would be give me one moment to share my screen. I think our network is moving pretty slow this morning, so I appreciate everyone's patience. Okay. So I'll just say too, I was monitoring the chat on my device. Something's going on with Kristen's laptop in the room. So if you have a question, please just don't hesitate to raise your hand or come off mute. I may not see it right away. It's just in the chat box. So I'm going to go back to a version of the view that we had looked at now nearly a year ago, when the One Big Beautiful Bill Act was passed, as well as New Hampshire's HB2 budget was passed as well, which introduced a series of different changes on the Medicaid program. They're summarized, focusing on the ones with a beneficiary impact or sort of program change on this slide. And the ones in sort of the teal color were from our HB2, House Bill 2. And the purple is coming from the HR1, One Big Beautiful Bill Act, which now is called the Working Families Tax Cut Act. But all of those are the same piece of legislation as the federal legislation that came out last summer. So last year in 2025, we did update the MAC about our increased pharmacy copays in line with HB2. We returned to some of our pre-public health emergency eligibility rules for processing eligibility in Medicaid. And then I have a little yellow dot for kind of where we are now. Coming ahead, we are continuing to work on a potential 1115 waiver to enable the department to implement premiums for Granite Advantage recipients. I wanted to highlight this to the group because once that waiver should be sort of approved to submit, we'll enter into a 30-day comment period and have at least 2 public hearings. When that happens, we'll update the MAC with those times. And, I think we're sort of hoping it might overlap with this meeting, but that isn't how it shook out. But we'll be sure to share that information if it is approved to be submitted and we have those public hearings scheduled. We'll also talk a little bit more today in the coming slides about some of the purple boxes ahead. So changes to Medicaid coverage for non-citizens, work requirements and 6-month redeterminations for Granite Advantage. The last row of 2028, we won't really get into today. There's not as much substantive material to share with you today on those topics. Just skip. This is really just another view of summary with effective dates. So these are some of the key department updates I wanted to put in front of NAC today on work requirements. DHHS did recently put up a website to sort of act as our landing spot for tracking these key policy changes, such as work requirements and 6-month readings that Dr. Frew was talking about. So this page is called State Covered New Hampshire. I've linked it here and I'll share these materials with the group following the meeting. And look forward to sharing this website too with the BAC for feedback. It's really meant to be a living page on, kind of a landing spot where we can keep folks updated as information becomes more final. When you look at it today, you'll see, it's a lot of high level information just because we don't want to put something out there that, is modified or changed later on. The second bullet speaks to, we've been working with CMS in partnership on a pilot tool that CMS is offering to states. It's called ME, but really what you need to know is it's a tool for easing income verification. So a couple months ago, we introduced this with a limited population in our Medicaid program, really for those who we can't passively verify their income. So our typical data sources that give us passive income verification don't match or verify on that individual. This is a tool that comes to you as part of the letter to provide that income verification, where you can scan a QR code or follow a link and use this application that's really meant to be sort of like TurboTax, where you can somewhat seamlessly import your income and work information. This hinges on whether you are working and earning income and whether that employer, your payroll platform is within the network of this tool. So our focus right now is really just making sure that folks can use it, get a sense of how often it is returning verifiable information. And that, will inform whether we kind of use it going forward. But at this stage, it's really more in a pilot phase. The third bullet is that we are participating in what's called an early awareness opportunity. This is also a CMS partnership that they're offering to all states at no cost. CMS is basically trying to add a layer of outreach campaign to states that are impacted by the work requirement policy, and give more broad outreach and awareness to beneficiaries through text and email if they've opted into that communication, so that folks can just expand our reach, make sure folks know to monitor our website for information and be on the lookout for the more kind of formal detailed noticing later in the year. Last bullet at the top here is that, we just kind of continue to work, and I have a slide kind of depicting this in more detail through the different system development pieces, policy development, and communication strategy that's going to support our implementation of those requirements. I also wanted to highlight, states are directed through the One Big Beautiful Bill Act to make some changes to non-citizens coverage in Medicaid. This will go into effect October 1st, 2026. The language here is from our website, and folks who are impacted will be noticed I don't think that's taken place yet because we're still finalizing identification of who's impacted by these changes. So summarized here, adults who are not pregnant must be a U.S. citizen, U.S. national, legal permanent resident, Cuban nation entrant, or compacted free association migrant to remain eligible for full benefit Medicaid. And important to note that eligibility for children under 19 and pregnant women, which includes a 12-month postpartum period following the end of pregnancy, does not change. These individuals will still be lawfully residing to be eligible for Medicaid. So no changes on that policy. This is just a high-level timeline, just sort of visualizing. Again, we're spending a lot of time on work requirements today. Sort of our path to January 2027, which is when they kind of fully go into effect. You'll see in March, we've already kind of passed some of these milestones of getting our contracts in line to start the system development work. We will spend a little bit of time this morning. I have a couple of slides on the CMS rulemaking. So a lot of states have been eagerly awaiting an interim final rule from the federal government. So this is basically a follow-up to the One Big Beautiful Bill Act, which is the sort of statutory requirement. And then the rule is what details exactly how states have to comply with these requirements and the more specifics of the federal expectation. In September, that's when our sort of required member noticing will be in place. It'll actually start in August. We think the first heads up letters will go out in August to people who are currently enrolled, but that will continue through the fall as new people enter the program, or just as a reminder, notification to folks in Medicaid and the Granted Advantage population. December, for someone who's newly applying, we'll need to demonstrate community engagement in that month. And then towards December, we also anticipate seeking GLPAR approval for our administrative rules, defining more requirements. And then that blue box at the bottom just is meant to highlight, we're doing kind of continuous outreach, stakeholder engagement through this whole process. And then the early awareness opportunity I told you about through CMS is going to take place between July 27th and the end of August. So again, really kind of like a layer on top of what the state will do, just to try and increase the chances that people will intercept and notice these updates they're getting. I'm going to pause here. Well, the next couple slides are going to get more into the final rule. Before I do that, does anyone have any questions so far? Otherwise, we'll just keep plowing ahead here. Just didn't want to talk over anyone. This is just a little bit of a view, again, on that CMS early awareness opportunity. This kind of restates what I said already, that they're just hoping to increase awareness of state Medicaid agency communication efforts. Includes that text and email outreach and website communications as well. I'll share this as follow-up rather than read through it all, but these are the kind of key points of the messaging, ensuring that folks are aware of the new requirement, they understand whether it would apply to them, based on the type of eligibility they have, what steps they need to take. I think number 3 is kind of important to speak to because, as of today, there is not a lot of immediate action for beneficiaries to take in preparation for this, with the exception of making sure that we have your current contact information and home address, because this really is the foundation of our ability to get in touch with our members. So if there is kind of like one thing to encourage action on in the present moment, it's really updating the state on contact information to be sure that we're able to get in touch with you when the time comes. Okay, so now shifting into the CMS interim final rule. On June 1st, last week, CMS released this rule requiring adults enrolled in Medicaid to prove they are working in school or doing community service for at least 80 hours a month. This is just, again, applying to expansion populations, which in our case is the Granted Advantage program. And this rule really just kind of sets out the framework that states have to use as they really get into implementation of this policy. So just to kind of visualize like where we are below here, you know, the rules released, we're, I would say, still in the phase of fully digesting and clarifying the requirements introduced in that rule. We'll share some of that with you today, but it won't be the end. There's going to be more to kind of clarify and communicate about. We will be preparing our state plan amendment. The state law that Rob referenced in his legislative briefing obligates us to present that state plan amendment to certain legislative bodies for approval. And we'll also be sharing that state plan amendment with MAC once it's drafted and ready. They just made the template for states to follow available, I think, on Friday. Okay, so the final rule, it covers a lot of different topics. We're not going to talk about everything today, but I'm going to touch on a few kind of key themes. The first being, how do you meet the work requirement if it affects you? There's 2 slides summarizing this. The first is obviously hours of work that's being done to get to that sort of 80-hour pool that's required. The final rule clarifies, some helpful clarification about like what qualifies as work. So just affirming that self-employment, gig work, in-kind arrangements, unpaid work that's not community service, all may meet this criteria in the federal rule, but that anything that's like a Medicaid covered employment service, very limited relevance in our state, but that wouldn't count towards the work requirement. Community service is another qualifying activity. The final rule presents some parameters there on what kind of community organization and what that host organization needs to do to make that a legitimate qualifying activity. The third is a work program. We are in active collaboration with Employment Security on this one to plan how we're going to make sure we can collect anyone's participation in the New Hampshire work program to qualify towards their 80 hours. And this lists a few different examples that are mentioned in the final rule. Okay. The fourth activity is education activities. So the final rule hopefully clarifies that if you're enrolled at least half-time, that is basically considered meeting the requirement. Another kind of benefit here is we anticipate a new data source here from the National Student Clearinghouse, which we think will give us a much better chance to passively verify that someone is a student and has that half-time status, so that they're not necessarily having to submit documentation to that effect. Number 5 just confirms you can combine different activities to meet the 80 hours, and below in the blue text is some detail on how you can combine activities. There's some parameters there about how hours are counted in each category. And then monthly income is another really important one. If income is earned on a monthly basis at least equal to the federal minimum wage multiplied by 80 hours, then that meets the work requirement, even if there's not specific detail about like which hours were worked in that month. And the pink box to the side is a little more like of a double click on that income verification path, which I anticipate will be a really important one for passively verifying folks who need to meet the work requirement. So if a person's monthly income is less than the federal minimum wage multiplied by 80 hours, and we don't have documentation of the exact hours worked, the federal rule gives us flexibility to estimate hours by dividing their Magi-based monthly income by the federal minimum wage. So that I think is also a helpful flexibility to just use the data we have available to the greatest extent that we can, and hopefully minimize the amount of manual documentation that has to be supplied. Okay, so that's, what makes a person compliant. I think the next really big topic is within Granite Advantage, within Medicaid expansion, who is not obligated to meet the work requirement. And we'll be calling these exemptions in the law and in the rule. They're called specified excluded individuals, which is kind of plenty. So we're just using the shorthand exemptions to talk about these. On the screen are the different exemption categories. There's, not new or less exemption categories in the rule compared to what was in law. So we did know about these for the most part and have been working towards implementing them in our system. But I would say the federal rule gives us a lot of the clarifying information on, what information the state can go off of to verify that someone falls into one of these categories. The categories are former foster youth, American Indians and Alaska Natives, parents, guardians, caretakers. We'll get more into that on a future slide. Disabled veterans. Disabled veterans is another category where we anticipate a new data source from the VA that will, again, hopefully streamline our ability to identify someone as a disabled veteran without them having to submit documentation to us. Medically frail or having special medical needs is another category already meeting TANF requirements. So the next two on TANF and SNAP, I think, can be a little confusing because it's basically saying if you meet the requirements of the TANF program or you're not exempt from requirements for SNAP and you receive SNAP, this exempts you from Medicaid work requirements. We'll be putting together some more material to kind of get everyone's head around that because it can get confusing. But I'll just say it one more time. If you are in compliance with your TANF requirements at the time we're verifying Medicaid work requirement, we don't need to verify the Medicaid work requirement. We could basically exempt that person. And same for,
I was just going to ask if we could go back to medically frail.
Yeah.
Because I feel like that is an area where the interim final rule kind of gave a little bit of a curveball depending on who you ask in terms of how restrictive it is. And maybe you were planning on going there, but I'm hoping we have a chance to double click on that.
We can definitely talk about that now. So we did not deep dive on it in the slides today because I think we need some more time to, if you think back to my highlighted, clarifying box, I think that's one where the department is taking a closer look to kind of understand how, how the interim final rule may or may not modify what we were planning already. But to speak to what you're referencing, Lisa Britt, the interim final rule establishes basically a functional status kind of concept where it's it can't be solely that you have a certain diagnosis that constitutes being medically frail, but there needs to be some aspect of that impacting your ability to meet the work requirement. And so it's referenced as functional status in some places or acuity in other places of the rule, but basically ensuring that there's also a component about ability to meet the work requirement and how your medical situation does or does not interact with that. This has been definitely a big topic in the days after the release of the rule. We are participating in a lot of different forums to learn more about how other states are interpreting it. And I think it will definitely be a big topic in a future meeting. But I'm happy to talk about it more now too. Carolyn, I see your hand is up.
Thank you. I have a question about the medically frail individuals and actually all of the exemptions, really. When the department knows that the individual meets the criteria, one of these criteria for exemption, will the department automatically exempt them? So, for example, people on waivers.
Yes. So
are medically frail. Will they be automatically exempt?
Yeah, it's a great question. So most people in waivers are not in Granite Advantage. However, there are some that are in a waiver program and are also Granite Advantage. So I just want to call out, it would be like a subset of the 1915C waiver recipients that we'd be thinking about here. I feel pretty confident saying like the department will be able to ensure that those folks are appropriately identified as exempt. I think we're still working on the process for that. Like what's the right way to do that. But I think you're right to call out that anyone in that situation, you know, we should have abundant information about their clinical status. Holly?
Thank you. While we're on this, I just wanted to uplift the concerns expressed by Lisa Britt, because all of our folks fall into this category, and we thought originally, okay, good, because I know that the department was planning on using some claims data for some of this work, and it looks like now that's not going to be an option. Are you trying to now think of other ways to determine whether somebody is unable to work, or are they going to have to come up with supplemental documentation from a provider to submit to the department?
So I will say, based on what we know today, we still plan to use claims data. I think it's not so simple as to say we're going to use claims data to passively identify folks and now we can't. I think that's not what's in the rule. The rule introduces just more parameters on like how you're using that claims data, what criteria, what clinical framework is being applied. That gets into a very like clinical space that I don't want to speak to today, but that's why I said to Lisa Britt, we really plan to come back on this with more detail. But the final rule does, I really reaffirm that states are expected to use information they already have available to make verifications wherever possible. And that if we have the data to make a verification available to us, we must exempt that person. I think it's really the ambiguity that we have right now is just further exploring this like acuity, functional status aspect and translating that into like, so what is the actual criteria we're applying and using what information? But based on what we've sort of learned and heard as of today, I do not think it's the expectation that no one would ever be able to meet the exemption based on claims data. Does that answer your question, Holly?
It does. It just makes it more complicated, but it does answer my question. Thank you.
Absolutely. Kathy?
I was wondering, I know this is probably an iron question, I have a lot of them, don't worry about but now these rules can restrict somebody's ability to work, right? I mean, unless they work too much and then they don't qualify for a certain type of Medicaid. But you're not saying these groups of people can't work at all, right? So these are people that the program would exempt from working, right? But they can work if they want to. Am I correct?
Kathy, can I repeat it back to you, make sure I got your question right? I think you're asking, it's not that someone is wholly unable to work. They just need to have some kind of medical or, health situation that it limits their ability to work, right?
Yeah, I guess it's because I mean, I understand that I would be exempt, probably, from having to work, but I do work. And I don't consider myself medically fragile. And that's probably just me, but I was just wondering about all that.
I think it's important.
May I?
I think it's important to remember that this applies only to granted advantage adults, not to the other categories.
Okay.
And so
I'm sorry, I got confused.
that's fine. There's a lot here.
Yeah, I'm trying to digest like 200 pages into a few like interesting slides. So it's definitely complicated. But yeah, it would only apply for granted advantage individuals. But I think you're still right that there could be people who are in granted advantage. They're like totally unable to work. But I think the key, right, is not that they're completely unable, but that there's some they have medical situations that interfere with their ability to work.
I just would like it to be more clear that you can work even a little bit if you want to, and it's not clear. That's all I'm saying.
If you are exempt, but you choose to work.
Oh, great question. Yeah.
It's not taking you guys.
Doesn't exempt you from not working at all.
Yeah, I'm gonna fully punt on that. I don't know. I don't know if someone, if they've met an exemption, can opt in. I don't know today if that would be allowable or possible.
Well, and I think the other part of that is you might meet an exemption criteria and work a little, but not the full
80
required number of monthly hours.
Yeah,
So
like 80 hours seems like a lot, but I don't want people to be. I just don't like the idea that people might think that they can't work at all.
Yeah.
So they might be thinking, well, what did I go to school for?
No, I think it's an excellent communication side that we're really talking about, like, 80 hours is the standard. And I'll just say, like, again, based on our understanding as of today, us identifying you as exempt. So, I mean, let's take the example of someone who's Native American, and we know that you're Native American, we'd be exempting you. But that doesn't mean that that person can't work, and their working wouldn't do anything to what our eligibility system is tracking, which is just following that fact that that person's Native American and defying the exemption.
I mean, it kind of defeats the purpose of the policy if we penalize people who are exempt from if they didn't choose to work. But you're right, but we don't know for a fact.
Great questions. I'm going to move on. Oops, down here.
I can't hear it all.
Can you? Sorry, Patrick, are you still talking?
She said she couldn't hear it all.
Oh, can folks hear me?
I think because you weren't talking.
Okay.
Yes, Olivia, I can hear you.
Oh, thanks. I wanted to quickly just touch on two. There are optional short-term hardship exceptions. Those are different from the exemptions we just talked over. That they're optional for states, and so this would be part of our kind of discussion with the different bodies that need to approve our state plan amendment, whether New Hampshire pursues any of these. One is related to the status of being inpatient or receiving institutional services. The second relates to there being a presidential disaster declaration in your area that would affect the ability to work. The third is related to areas of high unemployment rates. And the fourth is related to someone's need to travel outside of their community in a significant way to receive needed care. So again, we'll keep this group posted on New Hampshire's status when it comes to these optional short-term hardship exceptions. Okay, and then finally, I just wanted to touch on outreach, that the final rule also speaks to how people are outreached. Regardless, we talked a little bit to in August, there's going to be some heads up noticing coming. And then after initial noticing to beneficiaries, I think these 5 categories are just helpful to think about when we would be required at minimum to send additional notice. So whenever someone becomes enrolled, yes, they didn't know, they get that first notice at each eligibility decision. When the hardship exceptions change, that's only, if you are using those optional hardship exceptions. Whenever eligibility is reduced, and then upon CMS request, CMS can direct states to do additional outreach. So we will continue to share resources, and the slide I've linked material aids for this presentation. We'll share more as it comes out. We're expecting a pretty valuable summary to be released today or tomorrow from another organization. We will be bringing more presentation to the MAC on the policy and the resulting state plan amendments. I do think, going back to Lisa Britt's point about our cadence, that this might be a scenario where we reach out to say if we want to have an off-cycle meeting. So just be on the lookout for outreach from Kristen if we go that route to be able to convene more timely as some of these policy steps have to come together.
And if I could just urge the membership, when you get an email from Kristen saying, would you like to have a special meeting? It's really great, even if you don't want to still respond. The silence is a little bit hard, I think, for us to interpret. So if you could just make a point to respond to those requests, that would be super. And Olivia, I know you are pressed for time. I just have one question. Can you speak to premiums for Granted Advantage and premiums for CHIP?
Yes.
Like how those are progressing in the timelines.
Premiums for CHIP, I think I shared in a prior meeting we got. So both of them kind of started with policy clarification on the federal level. For CHIP, we confirmed that we'd only be able to charge a premium, 1 month premium at condition of becoming enrolled for those in that income bracket that are affected. And then because of the 12-month continuous enrollment requirement for CHIP, while premiums would be invoiced in that 12-month period, states cannot disenroll for non-payment in that 12-month period. In terms of when it could go into effect, we're working on the timeline there. For Granted Advantage, we did get some more direct engagement from CMS on an 1115, kind of confirming that would be the appropriate vehicle to seek permission. We are working to get that 1115 out, but the timeline would be influenced by CMS approval of that, which we expect to take a pretty substantial amount of time. Oh yeah, we do have enrollment summary material that we can share. Actually, Kristen,
I will burn on.
Yeah.
Scott's on. Heather's on to do Medicaid to schools.
Yeah.
Updates on those, but
so I'll leave.
But there are slides, but I wouldn't be able to comment on. But I'll send. Yep.
Yeah. Anything as a written update.
Yeah. Vern, you're on, right?
Hi, Kristen. Yeah, I'm on.
Hi.
I can't find my mic button, but I'm on.
Okay. We're just gonna do your slides.
So we'll go ahead to the next one. And so basically, the MCOs and the Medicaid unit are still making phone calls out to try to help with redetermination, making sure individuals know that they need to do that. For the month of May, we did have 4,933 individuals that were on the MCO call list. 2,270 of those were adults. The rest were children. Of those, 595 individuals actually received messages. They were able to reach out to and actually speak with 1,449 beneficiaries, or about 40% of the list. There were 287 individuals who had incorrect contact information, or they were engaged with an agency such as DCYF. And one of the things that the MCOs had been doing is making additional outreaches, often through either emails or posted, a little postcard going out to individuals to remind them if they cannot reach them by phone. Of those that they reached, 846, or about 58%, had already completed their redeterminations. So that was about 58% of those reached out had in fact taken care of that already. 510, or about 35%, still needed to complete their redeterminations, but they were aware that they needed to do it. We had a total of 9 individuals who had indicated they have new insurance, 4 adults, 5 children. And we're still running at about 3% of individuals who indicate that their address is correct, but they had not received information indicating they needed to do a redetermination. Have you go to the next slide. And so here is the information for the Medicaid medical unit, calling out for individuals who are not part of one of the MCOs. 57 individuals called, 41 reached, 72% success rate on that. 11 of them were already completed with their redetermination. Of those 57, only 1 had completed the redetermination and found to be no longer eligible. 26 were aware that they needed to do it, and 2 adults had indicated they had new insurance. No one had moved out of state, and there was only 1 person with incorrect contact information. So phone calls are still continuing with information coming back to the state for those who need to redetermine. Thank you. Any questions?
Doesn't look like it. Thanks, Vern.
Thanks.
Scott?
Scott, do you want to do the new stats, please?
I think he was on. Scott, are you still on?
Yep, I'm on.
Yep.
Sure. So, sorry, things were breaking up a little bit, cutting in and out, so I couldn't quite hear everybody.
Yeah, sorry.
That's okay. Yeah, so not much new to report here. So we received a total of 179 new applications for the month of May. We currently have at the end of May, we had 290 pending. 78 of them were in write-up, and only 27 of those were over 90 days for the adult cases. For the children's cases, at the end of May, we had 54 total cases pending. We had 7 of those were in write-up, and 3 were over 90 days. As I stated, we had a total of 179 new applications received at the DDU. Our overall timeliness for the month of May was in 91%. For cases that were within our control, that we were at 99%. So, you know, we're just plugging right along on this end. Anybody have any questions?
Just really quickly, what would be not in your control?
So what the regulations state, it said, you know, we're looking at 42 CFR 435.12 C3 I requires that we make a determination within 90 days. So that's part of the application, unless something prevents us from making that, such as the client failed to take action, such as maybe an incomplete application, incomplete releases, or the medical providers do not respond timely. So that's what kind of takes it out of our control. Within the what is within our control is, you know, and what's counted here also is the cases that we receive late from the district office, situations that are not within the client's control on that end at the district office. But anytime that the case is delayed due to insufficient evidence, it's basically outside of our control.
Got it. Thank you.
Sure.
You have any questions for Scott? Thanks so much. Good job.
I think Heather can do Medicaid to school. She's on.
Heather, can you log into Medicaid schools?
Yeah, I'm here. Can you hear me okay?
Yep.
Perfect. All right. I have a few slides I was going to share. For those who don't know me, I don't know if I've had the opportunity yet to really introduce myself, but I'm Heather Clogston. I am the Medicaid to Schools project manager for Medicaid to Schools at Department of Health and Human Services. And before that, I was at the Department of Education for a handful of years as the prevention coordinator, and also helped implement MTSSB in school districts across the state. So I'm really excited to be here and to do this work. So I wanted to throw some slides together because I don't know what's been shared since I've come on. So I wanted to give a really high overview of what we've been doing since I've come on and since we've contracted with our vendor Fairbanks. So Fairbanks was contracted last summer. I was hired in the end of September to help coordinate all of this work. We also had the opportunity to work with JSI to distribute a needs assessment survey, and that was completed and identify some of the needs and concerns that school districts had during that time. And happily, a lot of those concerns have been addressed over the time that I've been in this position. But a lot of the work we've been doing is relooking at our state plan to, our state plan amendment. Our time study implementation plan has been in development. We've been under development and launching the Fairbanks onboarding process, working on an LEA agreement, and lots of district outreach and education and just collaboration with education partners. Most recently, there's been a lot happening, I feel like, in the last month or two, and most recently, districts are now or should be now in the Fairbanks system, where they are working on their participant lists for the random moment time studies that will be happening at the beginning of the school year next year. We offered, in conjunction with Fairbanks, some 4 virtual onboarding sessions where school districts were able to log in and see what that system is like for that support. But we also had the opportunity to bring them to New Hampshire, and they presented with the New Hampshire Association of Special Ed Administrators at their annual meeting. They've been working with us internally weekly, but also they had an opportunity when they came here to New Hampshire to work with us in person. We, in the last couple of weeks, we had 2 in-person statewide Medicaid to School updates and training events with school districts. The largest being on May 27th, we had about 100 attendees, which was student service directors and special ed administrators with their administrative assistants. And those are going to be mainly the people within that system who are helping organize Medicaid to schools in their districts. And we were also able to provide really last minute coordination of it, but a small smaller North Country focus session up in Conway that had about 40 individuals, and then an additional shorter virtual session for those who weren't able to attend in person, just to be able to offer that flexibility. And again, like working with UNH Institute on Health Policy with a lot of Medicaid to Schools 101 training for school staff who just needed to learn more about Medicaid to Schools and these upcoming transitions. I just also wanted to highlight just the collaboration and partnerships that we've done. This is definitely not an exhaustive list, but we've had ongoing coordination with Department of Education, the School Administrators Association, Special Ed Administrators Association, School Business Officials, School Nurses Association, and so on. So right now, we're just really under development of the certified public expenditure model transition and the random moment time studies that are going to be taking place next school year. So there's been a lot of, anxiety and concern about it. But what I am finding now that schools are in that system, they've been in it for about a couple weeks now, they're feeling less anxious about it, which is really good. And I think that has something to, with all the education and training and opportunities that we've been providing them, and we continue to do that. We're going to be looking at some more education opportunities this summer and just continuing to encourage that online support with Fairbanks and any support that I can offer. I do, just because this is a super high level explanation and just being mindful of time, you're welcome to reach out to me. I'll make sure I share these slides, and my contact information is there if you want to have a bigger conversation on it and what's been happening. I welcome that. But if there's any questions, I'd happy to answer them.
Any questions for Heather? Thank you, Heather. I'm sorry you had to go through that so quickly. Our time together was fast.
Yes.
I don't think we have any of our other friends on the line for the other scheme.
That was kind of it, yeah. Because Karen,
End on time. So unless there are other comments or questions, I guess entertain a motion to adjourn. I'm sorry, did somebody make the motion because I can't hear you?
or we could stay.
I make a motion to and
Who?
end the meeting. Joan Fitzgerald.
Oh, okay.
I'll second.
Thank you.
Thank you for all your wonderful work.
Thank you.
All in favor?
Aye.
Aye.
Bye.
All right, everyone. Thank you so
Thank
much.
you.
Thank you.